I think the
So,
next speaker is Dr. Geetesh Mangal. For most of us in Jaipur, he is a very well-renowned speaker, practitioner, a very humble guy. I have known him for many, many years now. Uh, he's been practicing critical care for more than 10 years. He loves tele ICU. Actually, he is at the moment working as director uh, in the Department of Medical and Clinical Operations in a unique initiative called Hope, which provides tele ICU to a lot of hospitals in and around Rajasthan. He has many publications to his credit. He has been with us in the executive committee of ISCCM, has been a regular speaker at various platforms, and is now going to talk about as to how do you actually assess a patient from a critical care perspective on the bedside itself, and not just assessment, immediately react to it and give the first, you can call it the first aid or the basic care of that critical care patient in the surgical ICU. So over to you, Dr. Geetesh.
uh, thank you, Pankaj sir, for the kind introduction. First of all, I would like to thank Dr. Kapoor sir and Dr. Ravi and Dr. Anand for giving me this opportunity. So, uh, uh, Ravi, is the screen visible? Shall I proceed?
Yes, please. Yes,
Okay.
it is visible, sir. Please.
Okay. So, I'll be talking about the bedside assessment and basic care of critically ill patients in surgical ICU. So, I'll cover the basic assessment and the basic care of surgical ICU patients. So, as the time permits me around 20 minutes, so I'll just touch upon the topics which need to be emphasized during the stay of the patient in surgical ICU. I won't delve into the details of individual aspects much, and I'll be touching upon the quality assessment, which is very important for ICU. And at the end, I'll summarize my talk. So, the role of ICU care in surgical patients is multidimensional. As Dr. Zaveri has already pointed out, that critical care is a process and it is not a place. So, the role of ICU comes into management of surgical emergencies like burns, polytraumas, pancreatitis, many more, hemorrhagic shock, hemorrhages, bleeding from any cause, GI bleed, and many more. Then there is role of optimization of the patient. So many patients are brought to ICUs before they are taken up in OT for preoperative optimization, like any acute abdomen patient. And there is a role in optimization of coexisting medical illness. So these patients, before taken up for an emergency or a major surgery, they may need to be optimized in the ICU for a couple of days. Then the most common scenario, that is the post-operative care after a major surgery or operating on a sick patient for close monitoring of vital parameters. The need for mechanical ventilation, obviously we keep them in post-operative ICU, surgical ICUs, and then management of medical conditions and complications as they arise during the post-operative course of recovery. Then the rehabilitation, it starts in the ICU and then it may go a long way till the patient is discharged and even at the home. So that is a long run process, but usually it starts in ICU itself. So as we see, it's a multifaceted approach to the patient. So we need a multidisciplinary care model for these kind of patients. We usually the primary stakeholders in a surgical ICU, the surgical unit, which have operated on the patient, and then the critical care team. They are primarily like in our tele ICU model, we talk about model. So they are basically hub, and rest of all are on the spokes. So there may be surgical unit. They give their inputs. They do all the job in the OT and post-operative period. Their inputs are very important asset in the surgical aspects of the disease. Then the nursing team, which is the core of any ICU, they provide they are the end caregiver to the patient. Then there is rehab team, which includes the physiotherapist, the nutritionist, and in means counselors and psychologists if required for family and patients' psychological support. And then there are medical super specialties which are involved as and when required at the discretion of the critical care team. So all these together form a most multidisciplinary team deliver the care to the critically ill surgical patient. Now, coming on to the assessment and care part of the patients. So, the first and foremost would be history taking. So, a patient might be coming from emergency, or he may be coming after a RRT from a ward, or he may be coming up from the OT. So, a detailed medical and surgery history, surgical history has to be taken. We have to understand the presenting complaints and the diagnosis, the working diagnosis, which is usually available for the surgical patients. Then we have to keep into the past medical and surgical history of the patient. We have to go into the medication records. We have to reconcile the medications. It has to be discussed with the concerned specialist if it's required. And some of the medications be omitted, uh, uh, depending on the uh, surgery or the anesthesia which has been planned. Then the personal habits and preferences, any addictions, if they are there, they have to be noted, and the therapy perioperative has to be planned according to things. Then any other recent events which have happened, especially as Zaveri has talked about, any critical events which have happened in the ward, these have to be noted and taken care of. Then we have to review all the medical records, especially the preoperative investigations and any specialist inputs which have been taken or which are required before proceeding in for a major surgical procedure. Then the operative notes have to be looked into in detail. The amount of blood loss that is taken into the operation theater. Sometimes there are some procedures which are not planned upfront in the OT, but because of some intraoperative findings, some per-op findings, there are some additive procedures which are done in the operation theater. So these things have to be noted. Then per-operative anesthesia records have to be evaluated. The type and duration of anesthesia and the fluid and electrolyte reports per-operatively, the fluid balance, the blood products given, all these things have to be noted. Then there has to be a structured handover from the OT team. This is very important when we are receiving patients in ICU. So the structured handover usually tells you everything about the patient in brief, but the few things which are very important while you are caring in ICU is the post-op analgesia plan. So because this has to be initiated before inducing a patient. So the plan of analgesia is usually made by the anesthesia team, and we in ICU just take it forward next hours or a few days. So it has to be very clearly communicated by the anesthesia team to the ICU team, and any perioperative events, peroperative events which have taken place in the OT, that have to be communicated to the ICU team. These are the things which have to be taken care of, and everything has to be documented very clearly in the records. Now, coming on to the assessment of the volume status and the fluid balance, which is very important in these ICU patients. So, as we routinely see in ICU, the multipara monitor is there in the ICU. So, all the vital parameters are shown on the monitors, which includes heart rate, blood pressure monitoring, the respiratory rate, the temperature. The pulse oximeter shows us the SpO2 charting, the oxygen saturation. So, all these are continuously monitored in all the patients. Intake output charting has to be done by the nurses in all the ICU patients. It has to be done hourly. And the drain output, which is unique to surgical patients, and the color and the volume has to be monitored regularly. If there is any change in the color, if there is blood coming out in any of the drain, or any unusual finding from any drain, it has to be communicated to the team immediately. And insensible losses and large volume fluid shifts are possible, especially in GI surgery cases. So these have to be factored in when we are caring of such patients. So then maintaining adequate tissue perfusion. The ultimate goal is to maintain the adequate tissue perfusion. How do we assess tissue perfusion in ICU patients? That is basically by looking at the capillary refill time, and the global perfusion is assessed by looking at the serum lactate levels. And the easiest marker is the urine. So if the patient is adequate, pouring good amount of urine, adequate amount of urine, that is 0.5 to 1 ml per kg per hour, that means the tissue perfusion is adequate. And at the same time, while we are maintaining the tissue perfusion, we have to avoid fluid overload. So that is the balance we want to achieve in surgical patients. Regular monitoring of electrolytes, acid-base balance, and renal functions is very important, especially in patients with large volume fluid shifts and drain output, because this can lead to severe electrolyte imbalances, and at the same time, it can lead to abdominal compartment syndrome, which can lead to uh, dip in urine output, and acute kidney injury. So all these things have to be monitored clinically. So what are the clinical signs of hypovolemia? Uh, we all know the first and foremost is tachycardia. The patient may be having a thready pulse, narrow pulse pressures. He may be hypotensive, especially orthostatic hypotension, which is the initial sign of hypovolemia. Then poor perfusion, already discussed. Then sunken eyes, dry tongue. These are usually for ward patients or OPD patients who are having these problems for a long time. They are not much relevant in ICU practice. So, the common signs of fluid overload include dependent edema. So, in bedridden patients, we have to look at the sacral area of the patient, and we may not find the pedal edema uh, unless the edema is means it has progressed to anasarca stage. So, we have to look at the bony prominences, the sacral region. So there we can find some edema. Then prominent neck vessels, raised jugular venous pressures, nasal crepitations, and through fluid in cavity like ascites and pleural effusions on examination. These are all the signs of fluid overload, or maybe because of third spacing or absolute fluid overload. And point of care ultrasound can be really helpful in means evaluating the fluid status of the patient and targeting the fluid resuscitation and avoiding fluid overload. So we have a separate talk on this. So I'll just move on. So after once we have assessed the hemodynamic status of the patient and the fluid status of the patient, uh, apart from the usual vital signs, the fifth, according to WHO, one of the vital signs is pain, and it is very important in post-operative patients because it is a expected outcome after a surgery. So it needs to be assessed by using validated tools. For patients who are coherent and able to communicate, we can use a scale like numeric rating scale, which scales the pain at 0 to 10, 10 being the most severe and 0 being no pain. So this has to be the patient has to be made to understand it in his own language, and we need to document it repeatedly and treat it if the patient is experiencing moderate to severe pain. We have to treat it aggressively. Behavioral pain scale and critical care pain observation tool has been validated for use in mechanically ventilated patients. And most commonly, we use a non-verbal pain scale, which incorporates both behavioral and physiological components and can be used in patients who are not able to communicate. So, for ventilated patients, this is the adult non-verbal pain scale, which includes physiological and the physical parameters. They are scaled from 0 to 2. So, five components. The total score is up to 10. So 7 to 10 is severe pain, which needs to be treated aggressively. So pain control alone may allow patients to be comfortable enough to require no sedation. So usually we have a PAD bundles, which is pain, anxiety, and delirium. How a patient has to be addressed. These three things have to be addressed in patient in sequential order. So non-pharmacological interventions are also important. The simple interventions like repositioning or verbal assurance may be comforting to the patient. Pharmacological sedation may be indicated to help relieve discomfort and to improve synchrony in patients who are on mechanical ventilator, and it helps in decreasing the overall work of breathing also. So validated sedation scales have to be used, and protocols have to be laid down to help nurses deliver the sedation in a titrated manner at the bedside. So the most commonly used scale is the RAS scale for sedation. So the target is to have a patient who is under mild sedation, that is up to from -1 to -2. That is good for all the mechanical ventilated patients, unless he has severe ARDS or some other indications to keep him deeply sedated. So coming on to the choice of drugs. So, when we talk about the principle of drug selections, the critical illness brings some unique aspects. So, there is when the patient is in shock, there is decreased hepatic and renal blood flow, so which leads to changes in metabolism. The renal clearance and hepatic clearance are reduced. So, we have to adjust the doses accordingly, and we have to repeatedly stop the sedation and check for arousal of the patient and daily. And the use of continuous infusions also alters the pharmacokinetics of the drugs. So that brings into important pharmacokinetic principle of that is context sensitive half life. So, like if we take the example of drug fentanyl, which is commonly used opioid in for analgesia. So, as we use it in a single dose, the T half is around 30 to 60 minutes. But as we use it in infusions, it increases to multiple times, and it may take 24 to 48 hours to flush it out of the system, and more so if the patient is having hepatorenal dysfunction. So, we have to be very mindful when we are using prolonged infusions of sedative medications. Patient-specific factors such as obesity affects the volume of distribution of lipophilic drugs. We have to be mindful of the dosing. We don't dose it according to the total. We have to take the adjusted body weight in consideration. Therapeutic hypothermia decreases the volume of distribution and thus leads to changes in plasma concentration. So at the end of the just this topic about analgesia, so multimodal analgesia is usually the preferred post-operative pain relief. So we combine the pharmacological methods with other modalities like neuraxial blockade, peripheral neuraxial blockade, and central neuraxial blockade like epidurals to achieve adequate amount of analgesia with combining the benefits of all the approaches and minimizing the toxic effects of side effects of individual modality. So that is the best, most preferred approach for post-operative pain relief. Now coming on to thromboprophylaxis. So routine evaluation for venous thromboembolism risk and thromboprophylaxis is recommended for all critically ill patients, be it medically ill patients or post-operative patients. So mechanical thromboprophylaxis is considered best when patients have thrombocytopenia and who have a greater risk of bleeding. So this has to be assessed. Post-operative patients, we usually avoid pharmacological anticoagulation at least for 12 to 24 hours after surgery, and hemostasis has to be achieved adequately intraoperatively. So if we see frank blood coming in the drains, these things have to be just practice. What we all commonly do is decide the anticoagulation after a surgical round is done, after the patient's in the morning, like the patient is received from the OT in the afternoon or the evening. So next day morning, the whole team sees the patient, the surgical team, the ICU team, and then we start the anticoagulation, which is preferred with pharmacological therapy for thromboprophylaxis. So, for patients with renal insufficiency, unfractionated heparin is preferred, or dalteparin is preferred over enoxaparin, which is the most commonly used and preferred drug for anticoagulation. And we have to monitor the anti-TANA activity uh, in renal failure patients if we are using enoxaparin. For patients with severe liver dysfunction, anticoagulation is challenging, and it has to be, I mean, we have to titrate it very carefully because usually whatever we are monitoring, PTINR and APTD, all these are not very good markers. So it is very challenging to achieve anticoagulation in these patients, but definitely it should be considered. The use of adjunctive compression devices in addition to pharmacological prophylaxis, it did not result in a reduction in DVT as compared to pharmacological prophylaxis alone. So it is not very much recommended. And oral anticoagulants are not recommended prophylaxis in critically ill patients. So we have to use injectables, the subcutaneous lomoreplevate heparins are. Now coming on to the glycemic control during for ICU patients. So hyperglycemia, as we all know, is associated with increased morbidity and mortality. So, and hypoglycemia, as a result of treatment of hyperglycemia, it is independently associated with increased risk of death. Coming on to the mechanism of hyperglycemia, which is, we usually call it as stress hyperglycemia. So the reason is basically there is increased production of counter-regulatory hormones, that is catecholamines and glucagon, which lead to enhanced lipolysis and reduced insulin production. So it leads to increased enhanced gluconeogenesis and glycogenolysis, which leads to hyperglycemia and relative insulin resistance. So all these mechanisms play together to achieve a state of stress hyperglycemia, and it also worsens the glycemic control for a stable diabetic patient. So the hyperglycemia leads to mitochondrial endothelial dysfunction and immune dysregulation, and at the end of the day, it increases the chances of surgical site infection and overall poor outcomes. So for insulin therapy, when it should be initiated, so in critically ill patients, we use only short-acting insulins. The human insulin is preferred agent of for achieving glycemic control. The oral drugs are means they are not used, not advisable. So the threshold at which the treatment should be initiated is 180 milligram per deciliter, and the target is 140 to 180. There are a lot of studies which have compared strict control, that is 90 to 120, or 140 with usual control, that is 120 to 180 or 140 to 180. And there are different recommendations from different societies. But this is the most common recommendation which is there to keep the blood sugar targets at 140 to 180 milligram per deciliter. Once patient is clinically stable, he can be shifted to subcutaneous insulin. But normally we use a basal insulin, and along with that, when the patient resumes a oral intake or enteral intake, we can add a bolus insulin short-acting bolus pre-meals. So that is how we usually manage glycemic control. And coming on to the nutrition part, every critically ill patient staying for more than 48 hours in the ICU should be considered malnutrition, and medical nutrition therapy should be considered for such patients. Objective nutritional assessment should be done for all the ICU patients. There are various tools available, but none of them is a foolproof tool. So we can use subjective global assessment or other scores, Nutric score or nutritional risk screening. But these are means the available choices. So when to initiate? If the oral intake is not possible, early enteral nutrition should be initiated within 48 hours. In case of contraindications to oral or enteral nutrition, parenteral nutrition should be implemented in the first week of ICU stay. To avoid overfeeding, we have to means target a 70% hypocaloric feed to the ICU patients. And gastric excess is usually the standard of care, but if it is contraindicated from surgical cause, we can use a jejunal excess, or both are not available. We have to keep the patient on nutrition. Routine monitoring of gastric volume is not recommended in ICU patients. Then, coming on to the dietary requirements, so ideally indirect calorimetry should be used, but it is not commonly available. So, in absence of indirect calorimetry, simple waist-weight equations can be used. So, we usually give a energy requirement of 25 kilocalorie per kg per day and a protein requirement of 1 per kg per day for critically ill patients. And this has to be started from hypocaloric feed. Gradually, over first 3 to 5 days, it can be built to the actual energy requirement of the patient. So there are some contraindications to enteral nutrition. One is decompensated shock or severe life-threatening homeostatic abnormalities like hypoxemia, hypercapnia, or metabolic acidosis, active upper GI bleed, bowel ischemia, high output fistulas, then compartment syndrome, and gastric residual volume. If patient is not able to tolerate the feed, the GRV is more than 500 ml every 6 RD, then that is these are contraindications for enteral nutrition, and we have to switch the patient to parenteral nutrition. There are some special considerations like obesity, where we have to use the adjusted body weight for calculations of protein and energy requirements. In polytrauma and burns patient, we supplement enteral glutamine for first week or so. And then if we are giving parenteral nutrition, then we have to pay a special attention to provision of micronutrients, which are usually there in the pre-compartment bag, ready to mix bags, what we usually get in. They have to be there in the formulation what we are using. Then parenteral nutrition should be considered when enteral nutrition is not feasible or it is adequate. So we can give a complete parenteral nutrition or until the adequate enteral nutrition is established. So we can bridge it and wean the nutrition or complete enteral nutrition. It's the feeds. Coming on to the one probably the most important care aspect, that is the infection control measures. So hand hygiene is the most important aspect. Then we all know about barrier nursing. As indicated in immunocompromised patients, we see it in practice transplant recipient patients. Then there are standard care bundles for ventilator-associated pneumonia, the central line-associated gut stream infections, the catheter-associated UTI, and surgical site infections. So all these four are the most important hospital-acquired infections, which are preventable to a great extent. So all the care bundles have to be practiced to prevent these infections. And last and one of the most important topics, that is antimicrobial stewardship. So we have to have a judicious use of antibiotics. Mostly we see that in surgical patients, the antibiotics are given preoperatively, postoperatively, even after the discharge, with no clear evidence of infection. So we have to de-escalate the antibiotics as per the institutional protocols, but these things have to be kept in mind. So we all are familiar with these stages, the moments of hand hygiene and the steps of hand washing when we are doing any surgical procedure. This is of paramount importance. In prevention of SSIs, so as it is a surgical ICU discussion, so I thought that I'll just highlight the SSI. Razors for hair removal and use clippers instead. That helps in reduction of SSI rate. Using chlorhexidine gluconate and alcohol-based skin prep instead of povidone iodine. Maintaining normothermia with active warming. Perioperative glycemic control with target of RBS less than 180 milligram per deciliter, and appropriate timing and choice of prophylactic antibiotic. When the cases are long, the intraoperative period is long, the antibiotic dose may need to be repeated. So that has to means the anesthetist should be made aware of these things in long duration. WAP bundles, we all are, means we are practicing it. So these are, I'm not going into details. The WAP bundle and the COTI bundles and the CLAPSI bundles. So basically, all these bundles, there are a group of interventions which need to be practiced together and all the times to prevent infections in these at these sites. So this is usual care which has to be practiced in all ICU patients. Now coming on to the quality assessment of ICU care. So there are a lot of indicators which are classified according to the focus of evaluation. So there are structure related and outcome related indicators. So, this is example of few indicators what we commonly use to assess the quality of ICU care. Mortality related indicators, morbidity indicators like accidental extubation, reintubation, nosocomial infections. Then safety indicators such as compliance to hand hygiene, blood component transfusion protocol compliance, falls in ICU, sedation protocol compliance. So all these are for safety of the patient. These are compliance indicators. Then safety of ICU personnel, very important. Number of needle stick injuries, it's an example of that. And resource utilization and customer satisfaction level, which are more of administrative and managerial indicators. So we have to be actively involved in quality improvement process in our ICUs. So as a team, as all the stakeholders should be involved in that. And this is the process. We have to plan. We have to identify our problems. What are the areas of concern for our ICU care? Then we have to test potential solution and test them. Then we have to study the results and then finally act and have a team meeting, decide on the action plan and implement the best solution. This process has to be regularly instituted in all the departments, and we need to hold multi-speciality meetings and discuss the issues and form a implementation plan for the ICU. Now, I would just like to summarize my talk. So, the purpose of general ICU care is to provide a safe and comfortable environment to the patient while the primary disease is recovering. Pain assessment and assessment of anxiety and delirium is important for all the ventilated and ICU patients. Adequate analgesia and sedation should be maintained depending on the disease status and patient requirement. DVT prophylaxis should be considered in all the patients. Target blood sugar level is 140 to 180 milligram for most of the patients in ICU. Infection control measures should be followed stringently during invasive procedure and prevent nosocomial infections. Chest physiotherapy procedures may be required to facilitate removal of secretions and prevent basal atelectasis, especially in thoracoabdominal surgery patients. Early enteral nutrition is preferred. Collection and interpretation of ICU data is important to identify gaps in delivery of patient care and ensure continuous improvement in quality of care. Regular trainings and team activities are important to keep everyone motivated and maintain a pleasant environment in ICU. Thank you.
Thank you, Dr. Geetesh. A very comprehensive talk covering almost all aspects, and kudos to you for doing this in such a short 21 minutes time. Uh, Ravi and Anand, are there any questions coming in? Do we have any questions here?
No, sir. I just checked the Himanshi. There are no questions as such so far.
Okay, then I
Yeah,
think then we
there are
should
no
proceed with
questions.
the other
Yeah, we
talks.
can. Yeah,
I hand
yeah,
it over back to you.
Yeah,
yeah.
but I would
Uh,
request the faculty, I would request the faculty to generate questions for the on behalf of students, whatever you think are common issues, common problems. So please generate a discussion.
yeah, Pankaj sir,
Uh,
please.
So, Geetesh, you have been practicing almost now 10, 12 years, I've seen, and
Right,
you
sir.
worked in various places, and you've also worked extensively in surgical units. So, what you think makes a surgical care or surgical acute care different from the routine medical ICUs that we handle, and how you think we should not just this, we should make our students and the surgeons, upcoming surgeons, more sensitive. What are the issues which they should be looking at when they're seeing patients who are acutely sick in surgical ICUs?
Uh, so, most commonly, there are lines for various events in ICUs, like the first 48, 72 hours. Sepsis is not very common in post-operative, mostly inflammatory state. So many a times we are using the antibiotics. We are sepsis is at the it's everywhere. We are discussing any critical illness. Sepsis is the first thing. So we end up overusing antibiotics in these patients who are actually in the in the SIRS phase of the disease. So, and the other thing is what we commonly miss is these are thrombotic complications, perioperative MI, DVT, pulmonary embolisms. So, as most of the patients they have comorbid illness, coronary artery disease, or they are and all the patients are at risk of pulmonary embolism. So these patients are not receiving platelets, antiplatelets, what they were actually receiving before coming up for the surgery. So these are very common scenarios when the patient is, he gets critical in the post phase. These things have to be kept in mind, and uh, bedside ultrasound is actually used in diagnosing these things, a perioperative events like hemodynamic instability. Bedside ultrasound can differentiate between all these etiologies. I think these are a few important issues. Sepsis is overrated in surgical ICUs, I think, especially in first few days.
Yeah, I think I fully agree with you. Uh, Post-operative, it's not always the sepsis that kills. I think there are other more bigger killers. As you said, pulmonary embolism happening, a lot of hemorrhages there. So we need to be very sensitive about those issues. Uh, Dr. Ravi Singh, sir, you have
Yeah.
any comments or questions?
Yes, sir. One more thing I would like to add that whenever we read data about related to the surgical outcomes and surgical problems in our literature, it is always like more and more data coming from the Western world, and it is not the same story at our place. We have a little less height and little less built up patients. We have a little less physical capacity wise avid patients, and they are not very well versed. They're not very well off with the physical capacity part. So basically, the rehab care is the one missing link most of the time that we find in post-operative critically ill surgical patients. I think a lot of work need to be done in that particular area. It is not sepsis always that kills, but the poor general health or poor physical condition is the main culprit agent that comes up most of the time. I
Uh,
think Dr. Gitesh was making the same point.
Yeah, I think one small point I would like to make here. Not all post-surgical or elective complications. We have a lot of trauma happening in our country, and I think good trauma acute care is extremely needed. We need our own courses happening in medical schools. Not ATLS is very good, but not everyone has access to ATLS. So we should have. courses like, the Indian versions of trauma care. I think that is very, very important, which every medical graduate should learn, not just the intensivist or the emergency guys. I think that is important. I think with this, I would now like to
Yeah.
continue. We'll now continue with the further proceedings. Handing it over back to you, Ravi. Thank you.
Thank you, Dr. Anand, sir. Thank you, Dr. Yash Javeri, sir. Thank you, Dr. Geetesh Mangal, sir, for the very interesting talks over here. I'm really sorry for the technical glitches that happened in the initial part of this talks. Uh, Sir ended his words with trauma. And now I have our next chairperson, Dr. R.K. Singh, sir, from SGPGI Emergency Medicine Department, head of the Department of Emergency Medicine. I think there's no other person who understands better the trauma in acute care than an emergency physician head. So over to you, sir, to chair the next two topics. I would like to welcome you on. Thank you, sir. Please take it over.
Thank you. Thank you, Ravi. It's nice to be associated again with Professor V.K. Kapoor, and thanks him for the kind invite. The initiative of JST is well appreciated. I believe the audience in this session is enjoying the interactions and the type of topics that are relevant for critical with surgical background patients.